Thanks, Jack, and welcome everybody. This is the qiCommunity webinar for May. It's our lightning lunchtime webinar. Amy, you've pressed the record button, I hope, so we can make this available later for people who want to listen to it through our qiCommunity website. My name's Tony Lembke. I'm a general practitioner in Austenville in northern New South Wales, where it's a lovely sunny day today. It's probably about 20 degrees, I'm Chair of Faculty at the Improvement Foundation, and we're joined by a special guest, Paresh. And Paresh, can you introduce yourself and tell us where you are today?
Sure, Tony. Thanks for the invite to present today. So I'm a GP in Canberra, and it's equally sunny here, but I'm not sure the temperatures are as good as 20, probably hovering around the 12, 13 mark.
Now, Paresh, you're working with Ochre Health at the moment, and this project you've been doing with the assistance of the University of Canberra, the 3P pod, empowering patients in the waiting room. And Paresh, your practice was involved in the Wave 8 of the Collaboratives program as a participant, and that was that wave, you'll remember, where we were trying to improve prevent chronic disease, particularly diabetes, by early identification.
That's right, Tony. So as part of that wave, we did a fair bit of work around diabetes prevention, and we really created a bit of a process where we involved the receptionist in the role. And if we perhaps move on to the sort of next slide, where we've got a flow chart sort of showing the map of what we did. And so what we really did was we did three things really. We identified patients who were coming in on that day who hadn't had a diabetes risk score and were within the eligible age, and the receptionist had a copy of that list. And so as those patients arrived, they would invite them to sort of manually complete the OSD risk self-score and return the forms to the nurse, who would then enter them onto the clinical system, and then depending on whether they were high risk, medium risk, or low risk, there'd been appropriate interventions that would be offered. So this flowchart kind of demonstrates that process really, and we measured various things around this process.
So for that to be successful, we really needed that information, because that information often wasn't in the notes, I gather, their waist circumference, dietary habits, their weight, the amount of exercise they did. That's not information that generally one can automatically extract from the notes to get that diabetes risk assessment tool score.
That's right, and a lot of that data was missing. So when we did the collaborative, the aim was really to improve the diabetes risk assessments done. And if we look at the next slide, it kind of gives us an indication of what happened throughout that collaborative with the, and you can see that sort of top line, the overall number of diabetes risk assessments we were doing started to improve and increase. And then each of the columns under those data points represents the number of people that were either low risk, medium risk, or high risk. And then the other sort of run charts of dark in color, black in color, shows the number, the proportion who are at a high risk, who then went on to have a health assessment. So you can kind of see from this, when we did the collaborative, the kind of process worked. But you know, there were challenges with that, and there were challenges with sustaining it, because when things get busy in reception, you know, the priorities shift, and so that's where really the concept and the idea of the 3P pod was born.
So you started at the beginning of that slide there, Paresh. So 3% of your patients had, in the appropriate age range, had a diabetes risk. I would think that was in the higher end of the practices that we worked with, and certainly by the time you got to the end there, around 9% of all your patients that had the risk assessment tool. Again, that's that graph is exemplary, but you thought you could do better and you had a brilliant idea.
But yeah, that's right. So I mean, like I say, this worked during the collaborative, and but the problem with it was sustainability. And so the brilliant idea was, can we automate this process? Can we have patients who are coming into the waiting room go into a private pod, which is non-intrusive, and can we use that pod to electronically collect a bunch of data? And then the follow-on from that was, well, if we can get the pod to collect this data, can we present that same data back to the patient almost straight away to try and empower them and engage them in becoming more activated around looking at prevention themselves? So they were really the two key aims of the of this kind of 3P project. And
so that's a brilliant idea, Paresh, but we often talk about maximizing use of patients' waiting time. That's part of lean thinking, to use that waiting time to improve the records that we hold about our patients, so we know who they are and what they've got. That's really excellent thinking. But actually putting that into practice, many people have tried and not had success, but you did manage to get one of these pods installed in your practice. We might get you to show us, how did you do that? How did you get from idea to implementation?
So I guess two things. So we had a bit of a collaborative team when we started to think about this. And when you look at the collaborative, when you look at the team, it was not only health people, but it was IT bots from Data 61, design and marketing people as well from the University of Canberra. So we had a skills mix, which I think is quite unusual in health services research. We had people outside of health with design expertise, with marketing expertise, and with IT expertise, as well as health people. And we applied to the RACGP HCF grants and were successful in securing just under $60,000 to try and get this project off the ground. So what we did was held a few focus groups with staff, with patients, and we got some of the design students from the university involved in the process as well. And what they did was really interesting. So they actually just sat in the waiting room and observed the flow of patients and what patients did in the waiting room whilst they were waiting to see the doctor or the nurse. And then we got those students together in a focus group and asked them to think about, from their observations, how could something like the pod fit in to that workflow.
Oh, fascinating. So the students sat in like dummy patients and watched the patient's behavior. Wow, that would come
Absolutely.
up with lots of, there's lots of room for improvements in the design of flow in waiting rooms. So that must have been a fascinating thing for them the focus groups would have been really interesting to see what they thought of it all.
Very much so. So the outcome
you came up with the pod.
We came up with the pod, and so this pod you can see in situ. It's sitting in the corner of the waiting room, and you can see it's got some privacy, yet it's not completely concealed. And this really came out of the work that the design students really did with the observation. And where you look at this sort of wooden beams on the pod, they kind of match the staircase. Aesthetically, they designed it to fit in to the waiting area. There's a screen on the outside which has a rolling slideshow inviting patients and enticing them to come in. And as patients come in, this is what they see. So there's a welcome screen, and they can go in and sit on the stool there, press the start button, and it then takes them through the interactive data collection exercise, really. So would you like me to take you through that, Tony?
Yeah, is that an iPod built into the wall, or is it another bit of hardware?
So it's a mini Mac. So there's a mini Mac behind the pod there with an interactive screen.
Wow.
So
yes, I'd love you to take me through.
So when patients come in and they press the start button, it asks them a couple of sort of questions around whether they've been here before or not, and then it takes them to the to the next screen. Okay. So basically, the way the interactiveness was designed was around 4 modules. So we wanted everyone to complete some basic data, so allergies, smoking, BMI, and with the BMI we had an automated weight and height measuring machine, so they stood up and stood on the scale to measure their height, measure their weight, and plugged it back into the software here. So we wanted them to complete some basic information. We then also wanted them to complete some extra bits, some stuff around physical activity, some stuff around alcohol consumption, and a diabetes risk assessment. In the focus groups, what some of the patients said to us was, well, if we don't have time to complete it all in one go, we'd like to be able to come back and complete it a second time, which is why we designed it around the 4 core modules. So as each one of the modules gets completed, they can see and they can see their feedback, if you like, for that quadrant. And as they complete all 4 modules, the feedback is populated in all 4 quadrants. And when they've done this, they can hit the print and finish button, and they get a report card. And this is the front page of the report card, which you can see visually is designed in the same way as the interactive screen was, again, to allow them to relate to the process and what they went through. And then within each quadrant, that feedback is designed. So we might just go back, if that's okay, to the previous slide. So within each quadrant, that feedback is designed around the Rolf sort of reflection tool. So, and for those of you who are not familiar with Rolf, it comes from healthcare education, and it kind of talks about what, so what, and now what. So each one of those quadrants, it tells them what it shows. So if you look at the top left quadrant, it tells them what the BMI was. And it then shifts the thinking to, well, so what? What does this mean for you? And then, now what? So what do you do as a result? What action do you take? And each one of the quadrants does exactly the same thing. And so depending on where they've sat with the risk, the message that might come up might be subtly different. And then on the back of the report, so this is a report card they would get, and they can take this away with them. And then on the back of the report card, which is the next slide, there's just a few ideas for them. There's a website they can go to for further signposting, and there's a little area for them to put down some notes around what they want to do. So what's their action plan?
Looks fantastic. And was that the information that they entered, Paresh, was that available to their treating clinician or their GP immediately, or how was that integration undertaken?
Yeah, so that would be perhaps one of the limitations of the project. So it relied on the patient taking in the report card and showing that to their treating clinician. In an ideal world, we want to try and integrate this to best practice, so the data went straight into best practice. But unfortunately, the level of the grant didn't allow us to be able to do the software integration for that to occur. So I guess that's part 2 of the project.
No, well, that's fine, and I like that model. The patient actually is in control of the information and can present it to the GP, and then the GP has to be seen to be doing something with it. There's a bit of pressure on them to pay attention to it. So so that's excellent. So did people? What sort of people did you encourage to use it, and how successful was it in the uptake?
Yeah, so we encouraged anyone over the age of 18 to use it, and we were looking at from the research perspective, looking at getting more than 200 participants, and we had 250 participants in the end over a 3.5-month window. And this is the age range of patients who used it. So not surprisingly, the majority of the users were younger. But actually, when you look at the 65 and over, it wasn't insignificant. So we had a reasonably broad range of people using it, but the younger population obviously used it more than the older population. Interestingly, of the older people who used it, many of them were quite positive about the ease of using it. So it's more an anticipation thing. And for a couple of weeks during the project, we used the receptionist almost as a concierge, to try and get people to use it and encourage them to use it. And certainly that helped increase the utilization.
Okay, and then then you measured, I guess, the range of where people who used it fell in the different quadrants as far as their risks go.
Yeah, that's right. So we had, like I said, 250 people who used it. 40%, just under 40%, completed all 4 modules. And to complete all 4 modules takes 4 minutes. And the average wait during the course of the study in the waiting room was just under 15 minutes. And if we look at the proportion of people that completed each of the individual modules, they're shown on the slide. And if we just hit the next slide button, we should have some statistics come up, which gives you an indication of where those 250 people sat in terms of the different modules. Sorry, Tony, could we just go back to the previous slide just for a quick 15 seconds? So I guess the thing that stood out for me here is, the obese was 23%, over 37% were overweight, a third were inactive, a third were drinking unsafe levels of alcohol, a third were at high risk of diabetes. So that's sort of a third seems to be a statistic that stands out. And then we asked ourselves the question, well, is this new information, or did we already know about these people? So we compared the existing data we had for these patients and the new information provided by the pod. And so this chart, which looks complex, but it's really quite simple, the blue on this chart shows the data that's already in the clinical system in best practice. So this is the information we already knew. The green is the new information that we glean from them using the pod. And I think this graph gives you a sense that we've probably gained as much information as we knew from the pod. So we've probably increased our information by 100%, if not more.
Yeah. So so this is information that one might expect we would know about our patients, but we don't. It's just not in our system, and the pod was able to significantly increase the information you held about your patients over a relatively short period of time for those who participated. Did the people like it?
That's right.
Paresh, what did they think of participating?
Yeah, look, this slide really shows what participants thought of it, and we asked them a range of questions like, was the report card useful? Did it help improve your awareness of health? Did you feel confident about using the pod, and would you use it again? And you can see, generally speaking, there was a strong, overwhelming agreement, either strongly or agreement with it. The proportion who were neutral or less on this kind of 5-point scale were really in the absolute minority. So our kind of sense from that was those who used it certainly found it easy to use, useful, and found it helpful.
Yeah, 94% thought it was easy to use, which is an outstanding figure for a technology innovation. I imagine the design students must have been happy about that.
I think they were thrilled.
So Paresh, that was your the trial that you did with the pod. Is it, if we come and visit you in Canberra, is it still in the waiting room?
It is still in the waiting room, and it's very easy to switch on. So we actually had the Australian Digital Health Agency come and visit because they got wind of the project, and we have a chief clinical officer from the Digital Health Agency actually used the pod, and thankfully it worked, and it printed her report card. So it is very easy to use, very straightforward. I think that the big question for us is how do we integrate it into usual practice?
Yes. And what do you think about that?
Yeah. So, I mean, when we look at and reflect on the experience of the pod, it was overwhelmingly positive. There's a couple of hiccups. So the automated height measuring machines sometimes gave wrong results if it never reset itself. So the technology needed a time lapse to reset the height before the next patient came in, and it didn't always do that. So that's now been corrected, but that was certainly a hiccup during the project. The lack of data integration into the clinical system was also a barrier from the practice management perspective. So what we've actually done is created a way of producing a report which can then at least support a manual data entry process into the clinical system until we can think about getting the software integration happening. And to me, if you look at the last but one quote from a patient, this particular patient kind of said, look, this is a useful trigger and reminder about health issues that you have a vague sense of needing to change, but seeing the report card was salutary. Like, that kind of resonates with me quite a lot, because I think a lot of patients say that, they're kind of broadly aware that they're at high risk of diabetes, or they're overweight, or whatever it may be. They're kind of broadly aware of that. But actually having it reinforced helps push them along that activation scale. And so some of the other comments you can see are around people shifting up that activation scale. So, people going out and buying fitness trackers, sticking the report card on their fridge as a daily reminder. The thing I found really interesting was no one actually discussed the results with their GP. They sort of the ones who acted on it, decided to take ownership of it and do things themselves, which I thought was really interesting. One of the issues that arose in the focus groups we had at the beginning of the project was some GPs having reservations and concerns that it might increase and lengthen the consultation time. And actually, I think what we found was this was a really good way of A, getting the data, and B, encouraging patients to take some ownership of that.
Yes, because if the real work in chronic disease prevention is done by the patient, then activating the patient in the process is the first step, and that's what the pod seems to have been most successful in doing. The and you can see it, once expanding in use for all different projects or things you may be targeting at any particular time. Paresh, do you, if other practices who are listening felt that they wanted to demonstrate how much they cared for their patients by putting a pod in their office, the software that you've developed, how is that going to be shared? Is there plans to share it? What's your thinking around that?
Yeah, look, I think the honest answer is we haven't thought about it because the project sort of finished fairly recently, and we've been focused on writing the reports for the funders and doing the analysis. My kind of view on it is very much so, I'm a big believer in open source, and so as long as people who use it and the improvements they made, they were willing to also make open source to improve things, then I would be really keen on that. But unfortunately, it's not just my decision to make. So, I hope that's the direction we'll go in with this.
And has it been done elsewhere that you know of, a similar projects or concepts that you know about that have been successful?
Yeah, so not within Australia as far as we're aware. We did a fair bit of horizon scanning at the outset, and we didn't identify anywhere in Australia where this sort of work was being done. The use of pods is not an uncommon element of the way things are done in the US and perhaps in the UK as well, increasingly. But as far as we know, this is a first for Australia.
Okay, so maybe soon we'll all be building little confessional booths in our waiting room for our patients while they're waiting to see us. I guess having it not connected with the doctor, there's a possibility that people will be franker or more honest in the isolation of the little booth. That'll be an interesting study to find out subsequently. Paresh, thanks for sharing that with us. You certainly at Oka Health are out there and trying new things. I'm impressed that you were able to bring such a good idea that others may have had to fruition and implement it. And we look forward to hearing how you expand upon it and adapt it and continue to use it and improve it over the next few years. Don't let it just go after that. We're hopeful that we'll see it grow.
Thanks, Tony. And certainly, we're keen on making it grow. I think our thoughts for the next sort of phase of this is to translate some of the software into a tablet device. So, my big vision around redesigning the waiting room is to move from a traditional shop to an Apple shop type of concept. So, how do we redesign the waiting room to make it much more interactive, engaging, and walk the talk around health? So that's where I'd like to see this go. But I think this is the beginning of the journey.
Yeah, so we've started handing out pre-checks. When someone comes for an annual check, we print out what we know about them in a special format so they can make sure it's right, and height and weight, and having that on a pod form or in the pod, or even as you've just mentioned, on an iPad for the patients, would add value to that. There's lots of things to do while people are waiting that we could improve on.
Absolutely.
Thanks, Paresh, and thank you everybody for joining us today. Amy, the next qiCommunity webinar will be next month. I think that's on aged care. Look out for your Improvement Foundation newsletters for further information about that. Paresh will chase you up to find out how you're going with your pod, and find out further information. I know you've got lots of things to share, and we'll probably catch up with you again. End of Life Essentials is 1st of June at 12:30 is our next webinar. So thank you for joining us. All this will be made available through the qiCommunity website and on YouTube if others want to have a look at it subsequently. So thank you very much, and thank you very much, Paresh, for giving up your lunchtime, and thanks everybody for joining us.